This episode of the Nurse Practitioner Podcast is sponsored by the JANP Resource Center. Are you curious about what the effects of discontinuing CGM therapy is, or understanding the steps to interpreting the ambulatory glucose profile report? Find out the answers to these questions and more by visiting our diabetes resources on the JANP Resource Center. A link is provided in the episode notes. In this episode of the Nurse Practitioner Podcast, Dr. Yvette Conyers discusses routine foot care.
Well, welcome, Yvette Conyers. Would you like to tell us a little bit about your background and how long you've worked as a nurse practitioner?
Yes, I would. I'm so excited to be on this podcast. And just so you know, with this airing, this is actually Foot Care Month. So what an awesome opportunity. So I actually have been a nurse for almost 20 years and a nurse practitioner for almost 10 years. Can't believe how long that's been. As an advanced practice nurse, I've worked in various settings, school-based health centers, which was my passion. So that's working in high schools that have a health office there. And the role of a nurse practitioner is really to keep the kids in school, and they come to you for all the things that you can do as an advanced practice nurse. And when you think about it, education is linked to health. So it was one of my most fascinating nurse practitioner roles. I also just work with teens and adolescents in adolescent health clinics. And then for the last 8 years, I've been completing in-home risk assessments for Medicare recipients. So these are folks who receive Medicare insurance. You go into the home at the request of the insurance company, and you do a physical. You also do some subjective information, help with education, maybe some diagnostic testing, labs, etc. And really just trying to help reduce hospitalization, a true focus on treating chronic disease and communicating with the patients. And you also get a chance to see inside their home, to see any other barriers that may impact their health. Again, because we know not all health care is related to health. 80% of the health occurs outside. And so the home setting is something I'm very passionate about and love to visit my clients there.
Okay, that's great. So you said the home setting is what you're passionate about. Is that what led you into getting involved in this foot care?
It really is. And I'm going to share a little bit of a story, but I'll say as a nurse, and even more so as an advanced practice nurse, I would have to remove my client's socks and their shoes to complete a lower extremity assessment. As nurse practitioners, we look at their pulses to check the circulatory. We look at the sensation using monofilament testing. We obviously looking at skin color, etc. But when doing so, I began to notice that a lot of my nails of my clients, and many of them were very elongated, so long nails, they were very thick, they were very brittle, and then they were causing them problems with mobility, problems with walking. So I would notice that their gait would be a little bit off. They were leaning to one side or to another, or they maybe were complaining of some foot pain. And I tell you, when you remove those shoes and you remove those socks and you really focus on the care of the feet, we talk about a lot about a head to toe assessment. This is like a toe to head assessment. Your feet and toes, nails tell you so much about a person and systemic conditions that can be related to that we as advanced practice nurses do treat. So after I began removing shoes and socks and noticing these, I went back to some of my colleagues of the Rochester Black Nurses Association, and some of them are advanced practice nurses as well. And we had a wound care provider come to one of our chapter meetings that we have every month. And this was in 2019, so definitely a few years ago. But during that meeting, the question was raised about wound care and about foot care specifically. And the question that was proposed or raised was, how many wound care or foot care nurses are there of color in this Northeast region? Well, that came up because the goal and sort of what our mission and vision is of Rochester Black Nurses is true representation, because we know representation matters. And when the question was posed, the response from the wound care nurse was 0. That's right, 0. And so with that number and hearing that number, that there was no racial, ethnic diversity of foot care nurses and wound care nurses in that area, that stirred up something inside of me. So I decided to go ahead and pursue this advanced certification in 2019. And from there, I was able to complete some didactic and some hands-on training with the wound care and foot care nurse. And I was able to obtain my requirements to sit for the exam. we all know what happened in March of 2020. And so a lot of my training was unfortunately postponed or halted, but that didn't stop my journey. I eventually took the exam. I passed the exam 1 year ago, actually in November 2021. And since then have really been trying to make foot care nursing my advanced practice nurse role. I think for me next, I'll be going more specifically to get wound care certified because clinically, I think the scope and practice of a wound care, advanced practice wound care, which can be called CWCNAP, which is Certified Wound Care Nurse - Advanced Practice. But combining that with foot care nursing is just really going to help with addressing the healthcare disparities that's out there that we're seeing in our clients.
That is awesome, Yvette. You saw a need and you saw where you can fit in to help with that need. Can you tell me exactly what a foot care nurse is and what they do?
I sure can. But you know what? I'm going to start with some statistics because I think numbers really show why the need is so severe that we as nurses and hopefully can build this truly into a nurse practitioner role, being a foot care nurse practitioner or foot care practitioner. And that is my ultimate goal. It's going to take some policy change to help with that, which we can talk about later. But let me just break down some stats for you. So approximately 150,000 patients undergo a lower extremity amputation in the United States. About half of those are related to diabetes. So about 75,000 patients who do undergo a lower extremity amputation is related to diabetes. Other causes may include peripheral vascular disease, neuropathy, and even trauma. But of the 85% of those who do require a major amputation, the most initiating event, the thing that makes it occur, make them need to have an amputation, is they get a foot ulcer. Foot ulcers are very common in patients who have diabetes, but if it's unmanaged, untreated, 85% of them can have an amputation. And understanding that the lifetime risk of someone developing a foot ulcer and they also have diabetes is 25%. So 1 in 4 people who have diabetes will develop a foot ulcer. If 4 of us were sitting in this room, 1 of us would develop a foot ulcer if we have diabetes. As many as 50% of those who have diabetes, if they have an amputation, within 2 years will pass away. For those going into the hospital to get an amputation for foot lesions, those who are presenting with maybe some diabetic foot issues, 40% will require amputation. And then unfortunately, every 30 seconds globally, 1 leg is amputated due to diabetes. So if me and you have been talking now for the last 10 minutes, that would be 20 people globally who has received an amputated leg. 20 so far. I think it's important to also talk about not just the statistics per se, but also what do we do? And maybe we'll talk about that a little bit more, but I definitely wanted to share those statistics with you because I think it's important to highlight the need is so severe.
Wow, those are some amazing statistics. So do you want to go ahead and get into what a foot care nurse does?
Yeah, a lot, and a whole lot more. Our focus is on education and prevention. As advanced practice nurses, as nurse practitioners, we bring in that holistic view. We are looking at the person spiritually. We're looking at them culturally. We're looking at them psychosocially, emotionally, right? And of course, physically. But it's important when you're talking about someone who may develop an ulcer related to diabetes, that's just not something physically that's going on. That's something emotional going on too. And so you, as an advanced practice nurse, have to have that ability to provide that physical care, but also that emotional support. So for foot care nursing specifically, we're not just providing care for those who are healthy, but also for those who may have some comorbid conditions, some vascular related issues, some neurologic related issues, maybe some dermatologic issues. Even think about those who have vision issues. The inability to be able to see down to their knees, to their toes, to be able to manage just hygienic things. Or what about the person who is obese, may have some hip problems, may have some knee problems? Their inability to be able to provide that foot care for themselves is limited or non-existent unless they have a caregiver. And then you have to say, is that caregiver skilled enough? to know what they're doing. You see, as a nurse and as an advanced practice nurse, we have that skill set from our educational training and foundation to help us along the way. We also know that diabetes and vascular disease is becoming more prevalent. And care, again, that was previously performed by some of those caregivers or patients themselves can be provided by skilled clinicians such as us. We also know that foot care can decrease, routine foot care can decrease the risk of injury and infection. And if we're not treating injury and infection, maybe osteomyelitis, et cetera, that can lead to amputation, sepsis, death. And really, podiatrists and podiatric physicians, they are turning more to advanced diagnostic treatment modalities, which is fine. But being a nurse and being a nurse practitioner, we are natural choices to perform these evaluations and care for the routine foot care needs of the high-risk patients that we see all the time. As a foot care nurse and as a foot care practitioner, I'm obtaining comprehensive patient health history. I'm looking at my person's medications. I'm looking at their comorbidities. I'm looking at their health habits. I am aware of lower extremity physical assessments, so not just the knowledge of what's going on in the lower extremities, how many bones, the vascular situation, arterial situation, but also the skill set that comes with that. I am developing initial patient plan of care using the history and the physical assessment that I found and coming up with established foot care goals for my clients. And of course, you can't just come up with this established patient-centered plan of care. You have to look at the ongoing evaluation, modification of it to make sure that those clients' goals that they set in conversation with you are being met. I think in addition to those assessment type things, I'm performing preventative care on the feet and lower extremity to reduce complaints of pain, to promote foot health. And I'm also continuing to interview my clients, looking at their medical records from different providers that they have been to, their primary provider, any specialists they have seen, and looking at their risk factors, because I am trying to do prevention and education first and foremost. And then, of course, the treatment comes. I'm looking at types of pain. Do they have neuropathy pain? Is it musculoskeletal pain? Is it vascular pain? I'm looking at their skin integrity. I'm looking at their vascular status, looking at temperature, looking at their pulses, their hair growth, edema. And then I'm also looking at what is the function of the foot doing, their range of motion, deformities, their strength. Are they at risk for falls because their toenails are severely long or very thick or very brittle? I'm also looking at their neurological status. And so I am doing a lot, as I mentioned in the very beginning. And in addition to that, there are some other diagnostic testing that may be done, like an ABI, an ankle brachial index, where I'm using a Doppler to check to see if this person's at risk or if they can tolerate compression therapy, maybe for their edema, or if there's any compromised vessels that they may not be a good candidate for having some compression therapy. And of course, some other things that can be done. But obviously, I know my scope. And so if I'm coming across something that is not within my scope, I'm going to refer out. And that's what a foot care provider does. I'm going to talk to podiatry. I'm going to talk to vascular. I'm going to talk to derm. I'm going to talk to wound care if I need to, because at the end of the day, I can't do this alone. It's a team approach.
That's awesome. It shows that you have a lot of care for your clients, and also you do a lot of assessment. Is a nurse practitioner able to practice foot care nursing?
This is tricky. I would say yes, but many times you'll find that a nurse practitioner are working in podiatry settings, or they're working as an advanced practice nurse in a wound care treatment setting, or an inpatient working in the hospital going around doing wound care. And that's all well and good, but I'm hoping, and my goal is to truly be the nurse practitioner who is focused on providing that foot care for the clients, and then referring, again, making it a specialty role, and then referring out if need be. There are some barriers to folks receiving routine foot care that we can talk about later. So yes, a nurse practitioner is able to provide foot care, But when you get in the CMS and Centers for Medicaid and Medicare and billing and coding and all those type of things, you have to provide a lot of detail, and it can be very cumbersome in order to get routine foot care covered by Medicare, which is one of the barriers to people receiving this service, which is something that I'm trying to infiltrate.
Now, you mentioned you work in a podiatry setting as a nurse practitioner. Now, how is the foot care nurse different from a podiatrist?
Well, currently, I want to clarify, I don't work in a podiatry setting. Some nurse practitioners do work in a podiatry setting, working with a podiatrist. This is what point I want to clarify. Podiatrists are healthcare professionals. They are surgeons who also diagnose and treat conditions of the foot, ankle, and leg. I am not a surgeon. As an advanced practice nurse, I did not go on to get my surgery certificate and work in the OR and do some minor surgeries in the office. I like the family nurse practitioner role that I have been educated in and I have been trained in. And that's how I really want to maximize and fully get people to understand and comprehend the role of a foot care practitioner. So they are surgeons. I would not like to do surgery. And this is how I think we can work together. As the podiatrists are addressing fractures, sprains, even ortho can do this, bunions, hammer toes, arthritis, heel spurs, Morton's neuroma, some diabetes-related complications, and nail issues. Let me focus on some of the other things that patients don't necessarily need to come to this surgeon to get. I can do some of the routine foot care that can lessen up the surgeon as they likely get paid more money, and also they can bill higher in many states as a nurse practitioner where billing is not 100% equal. So go ahead, you do those more complicated things, and let me do some of the other things such as cutting and removing those corns and calluses, trimming, cutting, clipping, and debriding of the nails, hygienic and other preventative maintenance care, looking at the best skin creams to maintain that tone for either ambulatory or those bedfast patients. Let me do those things and everything else that I said earlier when you asked me the question of what does a foot care nurse do, so that you can do the OR stuff and you can do the more complicated procedures in order to get the most revenue.
All right, great. So you did mention a barrier, Medicaid as being one of the barriers. What are other barriers to providing routine foot care?
The major one, CMS, Centers for Medicare and Medicaid, that we all deal with as advanced practice nurses. Unfortunately, routine foot care is something that's normally not considered something that is covered by Medicare, unless the client has a systemic condition such as metabolic issue. Most of that is likely going to be diabetes. If they have a neurologic issue, or even if they have a peripheral vascular disease that then requires foot care by a professional. And even when you look at the dotted line in here and the really fine line, it says conditions that might justify coverage. So even if a person goes into a podiatry setting and they want to get routine foot care done and they have diabetes or they have peripheral vascular disease, that does not necessarily mean that their insurance is going to cover it or that they'll be reimbursed. So that's the major limitation, that this can be a cost to individuals who really do need it. And again, when you look at the statistics that I went over, you can see the need is so much greater than maybe what they are receiving. In case of an ambulatory client, if someone is able to walk, right, they're not bedbound, they have to have clinical evidence of mycosis, which is like fungal infection of the toenail. And they also have to have marked limitation of ambulation, pain, or maybe a secondary infection resulting from the thickening and the dystrophy of the infected toenail plate. Now, that's for ones who are ambulatory. For those who are not ambulatory, it's even more, they have to have that mycosis of the nail, but they also have to be bedfast, right? Or any other service that may be performed in the absence of one of those localized illnesses that I mentioned before, or injury. And so, again, in addition to all these, they have to have that systemic condition, metabolic, neurologic, or peripheral vascular disease. There has to be a clear circulatory embarrassment or areas of what we would say diminished sensation in the individual's legs or feet, in which we would assess for that. But if those things are not existent, the likelihood of CMS covering some of those routine foot care services that one needs is not going to happen. And so you may be thinking or maybe saying, you know what, well, I'll just go to a nail salon. That's okay. But the risk of infection, the education that you can get from seeing an advanced practice nurse or a registered nurse, and we know this, is so much greater. If you think about the times when you might have gone to a nail tech to get a manicure or even a pedicure, you think about what you're getting. If someone has diabetes, peripheral vascular disease, or just are elderly, can't move as much, or if they have some other mobility issues or obesity issues, going to a nail salon is not the first choice that we should be offering as healthcare professionals. It should be getting services provided by a healthcare foot and nail practitioner, such as me. That's the number one barrier that I'm going to just highlight with providing routine foot care there. Medicare, if it's medically necessary, they will cover every 60 days. But to really get them to cover every 60 days requires, again, that meticulous documentation for proper billing and coding, because in the realm of podiatry, there can be a lot of misdocumentation and fraudulent activity. So crossing your T's and dotting your I's are very, very necessary.
Thank you, Yvette. That was great information, great statistics, and just very informative as far as what's involved in healthcare. I don't have any other questions, but is there something else you'd like to add as a last thought?
Well, a lot of times I think we talk about barriers and we don't include action. I want to spend just a little time talking about, okay, well, Dr. Conyers, Yvette Conyers, you a nurse practitioner, you identified these barriers, but what are some things that we can do to remove those? And I want to say nothing can be done without health policy changes, without reforming action. And so I think it's important to recognize that the major barrier that has to be addressed is that CMS, Center for Medicare and Medicaid, need to recognize routine foot care as a health service that should be covered regardless of any presence of a systemic condition, and that preventative health care alone needs to be recognized and can be a major cost savings to our healthcare system. If globally someone's getting an amputation every 30 seconds, and out of 150,000 people who are receiving amputation, 50% of those are related to diabetes, we have some pre-work to do in terms of prevention, in terms of primary care, and not the focus on tertiary care. So we really need to be changing our lens and looking at what we do as healthcare providers and really focusing on that preventative piece and education piece. I think in addition, recognizing that as an advanced practice nurse, I'm not a threat to podiatrists, or at least I shouldn't be seen as a threat to a podiatrist who, if we work together, and from the stats I read earlier, we are all better together. We're stronger together. We can be able to address these patients' needs much better if we are working cohesively as a team. And so I think really our physician colleagues, not seeing us as a threat in some of the things that we are able to do, but you know what? Give a little bit of rope. It's okay that we take on some of these things so you can continue to work at your highest level of preparation and allow me to work at my highest level of preparation. We are not in competition. We at least don't have to be. And also think that recognizing foot care as an advanced practice role, not necessarily just for those who are going for wound certification, ostomy certification, or continence certification, but those who are going for foot and nail care certification, that has to be recognized by the certifying bodies as an advanced practice role in itself. That's what I really want to end with. We can't do anything without policy change, without procedures changing, without organizations and government recognizing that preventative care and primary care is going to be so much better for everyone than the focus on the tertiary care. Thank you so much.
For more great content from the Nurse Practitioner, Be sure to visit us online at tnpj.com for the latest NCPD articles, columns, and much more. Please leave us a 5-star review on iTunes and Spotify, as it helps with the podcast's visibility and helps us to keep bringing you this great content. Also, don't forget to follow us on Facebook, Instagram, and LinkedIn at the Nurse Practitioner Journal, and on Twitter at TNPJ_journal. Thanks for listening. This podcast does not constitute medical advice and should not be taken as such, and does not replace professional judgment or advice. The ideas and viewpoints expressed on this podcast do not reflect the official position of the speakers, authors, affiliated organizations, the Nurse Practitioner Journal, or Wolters Kluwer. Please note that the hosts of the Nurse Practitioner Podcast are not clinicians. However, we created the Nurse Practitioner Podcast to bring you relevant clinical information by NPs for NPs. Thanks again for listening.